Good afternoon, everyone, and you're all most welcome to today's conference, focusing on the consequences of living with HIV infection from the women's, children's, and men's perspectives. Our speakers are Lorraine Sherr, a clinical psychologist and professor of clinical and health psychology at University College in London, and José Catalán, who is an honorary consultant psychiatrist in South Kensington and Chelsea Mental Health Centre in London. Their HIV-related clinical as well as research work are very substantial and very, very impressive. Together with Barbara Hedge, who also lives not in London but Liverpool?
She's now in Kent.
In Kent, okay. Lorraine and José initiated and launched the first AIDS Impact Conference in 1991. It is an international behavioral and psychosocial science conference that addresses issues related to HIV and AIDS prevention, treatment, and care. So let me now leave the floor to Lorraine Sherr, who will address HIV challenges for women and children, a global overview. Her presentation will last until 2:30, followed by a coffee break, and José Catalán's presentation will start at 3 o'clock and runs until 4:30. And after that, we would like to hand over Guldarken that I will talk more about when time is like 4:30. So please, Lorraine, take the floor.
Do I need it?
No, you have
Oh, does this do? You can all hear me, even if I whisper. Oh, wonderful. Well, good afternoon. It's a real pleasure to be here and also a privilege. I've tried to put together loads of work that we do and that I'm involved in, just to get you some kind of an idea, a taste of what's going on. But what I'm hoping really is that you will interrupt me, that you will ask questions, and that you will talk to me. In fact, if you're all very quiet and nobody asks me any questions by about half an hour, I'm going to assume that you are asleep, and I'm going to sneak and go and see the wonderful city of Stockholm. So let's begin. I work a lot with women and children, and I'd like to give you some idea of psychological well-being and mental health, which is my area of focus, but it's all kind of intertwined. We know that people with mental health problems are more likely to become HIV infected in the first place. So there's a lot of evidence and data that shows amongst members of the population who already suffer, and we can understand the reasons for this. So, for example, if you have a mental health problem, you may be more likely to have a risk behavior. Some particular mental health burdens, like, for example, alcohol use or drug use, it links you into the behavior. So it's a complex kind of cycle. And we also know that people with HIV, even if you never had a mental health problem to start with, may well develop a mental health problem, and they have more burdens than the general population. And of course, you who've worked in this area would know the kinds of reasons to trigger that, the trauma of diagnosis, the impact on relationships, the impact on jobs, on economy, on family. It becomes a kind of a mushroom and very, very complex. And we also know in this kind of circle and cycle that mental health problems can have an adverse effect on very important elements of the epidemic, an adverse effect on transmission of infection, an adverse effect on living and coping with HIV, and of course indirectly on the health outcomes. So if it has an adverse effect on adherence to your treatment, your health outcome is compromised. We know that you do have to adhere for lifelong treatments at the moment, which is quite a burden. So what are the mental health sequelae of HIV? And that's one issue, but there's also mental health sequelae of the treatment. And we're seeing in our clinics people who are reporting things like treatment side effects. For them these days, this is the first illness experience that they have with HIV, is the treatment side effects. So living with these side effects and coping and adjusting with them all provide a very complex sort of mosaic of HIV and mental health. What I'm going to try and focus on for you today is I'm going to look a bit at HIV in women. Oh, yes, you're awake.
For just another second.
Oh, sure.
We just decided to take a picture and we wanted to feel awake.
And I will leave it with Lena, so you can we can circulate to everybody and save your cameras, but take pictures with pleasure. With pleasure. Is it? Do you have your picture? Good. So that wasn't a real question. That was a request, but not a question. So I'm looking at you and I'm waiting for a good question. So what I'm going to try and do today is to talk a little bit about HIV in a woman, a little bit about children. Much of my work with children is based in Africa, but it's nice to talk in an audience who are already nodding. You know, artificial boundaries are strange. So medicine divides obstetrics and pediatrics. Psychology doesn't. We just see childbirth and the new baby as one. Politics divide countries. This is Africa, this is Europe. But who are our women in London? They're very often people who have migrated from all over the world. They come from and they go to. So we have different kind of boundaries. And I'm going to end my talk by what I think is a new and emerging problem. It's a tomorrow's problem, but one that we haven't given enough attention to. The advent of mother-to-child transmission prevention really means, well, for certainly, I don't know what it's in Sweden, but I know in my hospital we haven't had a positive baby born for maybe 9 or 10 years. I'm sure that that's the situation here. But what about HIV-exposed, uninfected children? What do we know about that? Are we studying them? Do we know what's going on with them? And I want to give you some insight to that group, what we know, and maybe a future research and clinical agenda. Okay, so now we have a bit of a marathon, lots of very interesting things. I find the whole area so fascinating, so excuse me if I give you too much information, and if you want, I've left out lots, so if you have any questions, do ask them. Now, what is the gender differences of the impact on HIV? And I've tried to look through the literature to kind of give you an overview and a synthesis. Some women report very much shame and guilt associated with HIV infection. When you look at the quality of life studies, very often women have scoring lower on quality of life. We do not know if this is triggered by HIV or just compounded by HIV. It may be that would be true in other diseases. We do know that women's sexual activity is adversely affected by HIV infection right from the moment of diagnosis and for many months later on. We know that it has effects on health-seeking behavior, medication adherence, and clinical outcomes. Very well documented in terms of the gender differences. And what are they? When you talk to the women, they report decreased sexual desire. Some women report very poor sexual functioning and sexual inactivity, and that's quite commonly found. The coping strategies and the ability to disclose their HIV, to tell others about it, to partners, and sometimes the partnerships break down, so the ability to form new partnerships and relationships, and empowerment to practice safe sex may be affected negatively according to gender. So women have a very different and very special role, which we really need to understand. What are the burdens? Well, I'm listing them, but I think anyone who's done work in this field will know that this is just an indicative list. Economic burdens, employment, children, family, relationships, migration, very true in London, and I'm sure it's true here, support, disclosure, and of course stigma. Stigma is a strange animal which is associated with HIV profoundly, and it affects people. It affects their own views of themselves. It affects what they do. It affects how they live and how they adapt and cope. I have some data on women in the UK, and I think maybe it's very similar, and I'd be interested to hear if anyone knows about the exact data in Sweden. But just as of this last year, when the statistics ended, we had 31,600 women living with HIV in the UK, so it's large, and 31% of people living with HIV in the UK are women. We also have an imbalance. When you look at heterosexual men in our statistics, we find a report of 19,000, and heterosexual women living with HIV, the numbers are higher. Now, what is that imbalance? Is it that women are more likely? I mean, I believe it's probably that women are just more likely to be diagnosed. They're more likely to be tested. The imbalance is probably reflecting the way that we actually have neglected heterosexual men in the UK, because women are routinely tested in antenatal care, routinely. And so we have a different profile. They're not coming forward when they're sick. They're coming forward early on in the course of disease, and have been for a long time. So very curiously, when we did a study now, 9 or 10 years, we put a question to the staff, amongst many questions, was, do you test the men? It's such an obvious question. And we were laughed at. This is an obstetric clinic. They said, did you get your questionnaire wrong? They were laughing at us. Women have babies. Excuse me, but what about fathers? So to them it was almost ridiculous. It was a very interesting dialogue. Maybe 9 years later, they might come to the... But the whole idea that you have a pregnant woman with HIV and you don't think it's a normal routine to bring her partner in. And then some of the obstetricians said, oh, well, you know, Lorraine, some of these women, the partner is not the father of the baby. So what? She's probably still having sex with the partner. You know, it's a kind of almost paternalistic attitude, and very strange, but I don't know if you have the same difference in the numbers, and sometimes the numbers don't tell you the whole truth. Your action in terms of your testing and your outreach is what tells us the truth. So when you try and look at the mental health of women, it's also very interesting because the literature really focuses a lot on HIV and reproduction. So we know quite a lot about pregnant women, but that's only 9 months of a woman's life. And or maybe, you know, in the UK you have the mean number of children is 2.2, so 18 months of a woman's life. And the rest of her existence we don't really focus on. So there's more to women than just childbearing, and there's more to women than mothering. And our models need to understand that and take that into account. And then again, with aging and HIV, there might be very specific considerations of HIV in a woman. So I'm looking very forward to Dr. Catalan's talk later on this afternoon to see if we do know what are the differences, what are the needs, and what is the state of the data. That's at the one end of the scale, the aging. What about the bottom end of the scale, the young woman? Well, again, when you look at the stats, and I've given a talk at UNICEF, when you look at the data, have you ever looked at the UNAIDS statistics? It calls children. If you're under 18, you're a child. You come under the child, adolescence and child. Suddenly you have no gender. You only get a gender when you turn 19. So, and isn't that crazy? You know, and I promise you, I've said to UNAIDS myself, disaggregate by gender for all children, we want to know. And when you look at studies, you find very interesting differences in the number of boys born, in the transmission rates between boys and girls, in the IQ cognitive impact. We need to know this gender data. So we're gender blind for 18 years, and then we wake up. So I want to present findings from our study looking at the challenges for women, and I'm going to discuss a little bit of our findings from one little study in London, but I'm going to be quite quick about it. And the study preceded a nice study that's going on at the moment that hasn't concluded, called the PRIME study, where we've gathered, and Shima Tariq is heading up on that study, which I'm involved in, gathered data from over 1,000 women in the UK. And I think that it is a really good example of what needs to be done, and other studies that might be important to look at, trying to gather data on your own woman. And these are the mental health factors that I've seen: quality of life, depression, anxiety, coping, disclosure. And I also always talk, when I do, that we shouldn't concentrate on negative mental health. We also should look at positive mental health, like resilience and coping, because we have a lot of resources that we do need. Mental health is not necessarily always negative. It could be good, could be good. From our experience, it's just 3 steps. The first step is you have to identify mental health problems. If you don't identify, you won't find them. And it's very interesting. If you look at the clinics, people have routine viral loads, they have routine tests, we have routine data that we gather. Why is it not possible to simply put in a routine mental health screen? Very easy. You can do that at baseline, and then you can see if they change, if they go up, and you can identify the problems. Very often the barrier is that clinicians don't know what to do with it. If we find a problem, what do? So we have 2 pathways. You either deal with it, or you refer it. And that's quite straightforward. And I think we can do a lot of training, because a lot of mental health problems could be dealt with by the primary physician or the primary nurse or caregivers. But I think, organizations like this, that's a good place for referral. If we can't deal with it, at least refer it to a place who has the time, the expertise, the resources, and the caring to do it. And once you refer, you have to have something to offer. You have to have interventions. And is there evidence that we can do something? Well, there's good evidence globally. We can't get rid of it all, but we certainly can have good interventions. And what are they? Well, it's a literature that would keep me here for a long time, but my plane is tonight. So I'll just try and summarize some of the interventions. These might be familiar with you. I'm not sure what you do in your groups, but psychosocial group interventions, there's quite a lot of good literature that says these have benefits for many people. And when I looked at a very nice systematic review from Van der Heijden last year, they picked up 16 trials, and they're showing very good effects. And when I looked up those trials, 10 of them were men and women, and 2 of them were women only. So we do have some data on women. And it showed that these group interventions had a small effect on depression, but more limited on anxiety, coping, and stress. So the evidence in that review was not great, but it was there. The EVE study in France, a smaller sample size, large number of side effects, only half have found self-care strategies to manage. So this was just looking at naturally what were people doing, and quite interested in what did people go out and find solutions for themselves. Barris has done a review of non-specialist interventions. And if you look at the 9 articles, quite mixed results, but some had effects and some not so good. So what did we do? This is just a study of women in the UK. We took all the women in the clinic in my hospital, and we interviewed them. We used some standardized mental health measures, which I'm sure you're familiar with. We looked at anxiety, we looked at depression, we looked at symptom experience. We particularly wanted to ask about suicidal ideation, and we looked at sexual functioning. And very interestingly, we also wanted to look at menopause, because many of the women are experiencing menopause symptoms, and are they getting any care or any help? And this is just who we recruited. This is just at our center. So we had 272 women who came through the door, of whom 251 were eligible. We excluded people whose English was not sufficiently good for them to complete the questionnaire. And of those, 170 accepted to participate. It was about a 67% response rate. And then we had 140 usable complete questionnaires. Some of the scales, you have to have an answer on everything to get a validated score. So if you didn't complete the questionnaire fully, it was not very usable. Who are our women? They were aged 21 to 60. Many of them were well educated, 33% with university, and roughly half were in a relationship currently. And the ethnicity was quite mixed: Black African, Black other, white, or some other ethnic minority. And I wonder, this is probably very similar to what it looks like in other European cities, I'm sure. That might reflect some of your your institutions. Looks very different when I do studies in Africa. So we looked at general health and treatment. Most participants led quite healthy lifestyles. Only 26% had ever smoked, and of our women, only 8% smoked currently. Less than 20% drank alcohol on a weekly basis. 85% of women had never smoked or injected drugs, and 95% of women had had HIV antiretroviral medical treatment. So a very high uptake of treatment. And I imagine this is not typical, because wherever I've worked, this really reflects a hospital or a centre of excellence hospital, and a country where you have free HIV treatments and care available on a national health service system. I even imagine, like in the USA or in South America or other European countries, we might see a whole different array. But that was our women. And our treatment adherence looked quite interesting as well. 95% were on treatment. Of those, 82% had started but not stopped. Then we looked at how many doses they'd missed in the past week, and you can see it's slowly going down. So it's wonderful to say 95% were on treatment, but then you see it chips away. No doses missed in the past week, only 63%. All doses taken under the correct circumstances. So now the newer compounds, you don't have to have such difficulties with with diet or timing, but that goes down again. All doses taken in the correct time period, and only 46% had kept to the same regime. So slowly you see the treatment experience showing a very different picture. What about mood? What did we find? So looking at some of the psychological symptoms, 90% reported worrying, 90% reported feeling sad, 81% feeling nervous and anxious, 80% irritable. So there's a lot of findings. I just picked those up just to try and reflect to you that here you have this large group, but very, very high burden of mental health problems. So let's look in a little more detail. Anxiety, no risk for anxiety. And on the scales you have a cutoff, and the cutoff is to indicate where you would perhaps refer. It's sort of indicative of a diagnostic of anxiety, and perhaps that's a point where you would refer on to psychiatry or psychology. So mild anxiety 14%, moderate 11%, and severe 8%. So that's quite a high burden of anxiety. And when we look at the at depression, 55% had no risk of depression, so remember that there are a group who are doing fine and who are doing well, and they at that point in time are okay, but 29% had mild depression and 14.8% had quite severe depression. And half the participants, and that's very, very high, reported that they had suicidal thoughts in the previous 7 days. And we do know from the suicide literature that suicidal ideation is a burden in its own right, but it's also quite predictive of people who do go out and have suicidal acts, very often had suicidal thoughts that preceded them. So that's a worry. Pregnancy, most women had at least one child, 26% of the women had no children, 12.4% had a child who had died. Remember, a woman whose child has died, that's a bereavement which is lifelong. Women don't get over that. It lives with them forever. And 58% had experienced pregnancy loss. So they'd experienced either a miscarriage or a termination. And 20% of those had experienced it multiple occasions. And the cause of the loss, high rate of termination of pregnancy, high rate of miscarriage, and 4.4% stillbirth, which is elevated compared to the general population. What about the satisfaction with care? So you can see pretty much very high satisfaction rates, but this sort of small little group of people who were not satisfied, who were not respected, who didn't have good discussions about their delivery or about feeding the baby, and that shouldn't be there. It should be, everybody should get a good service. We looked at the sexual functioning index using something called the FSDI, which is an index which says the lower score, you have greater severity of sexual dysfunction. And we found greater than 23 normal sexual functioning, 18 to 23 was mild dysfunction, and then it breaks it down to moderate or severe. And the mean score for the group was 20.2, which I suppose falls into the mild dysfunction range. So it does show you that there is something going on there, which is worrying. So looking at the mental health burden, we were also quite interested because we'd measured anxiety, we'd measured depression, we'd measured suicide. Did that cluster? Were there people who had one and the other? Were there people who had comorbidity? Did they have lots of it? And we found, we tried to divide them into those who had no mental health problems at all, those who had single burden, and those who had multiple burden. And we found that the mental health burden was significantly associated with symptom distress, physical, psychological, and with sexual dysfunction, and with adherence. So basically, we're finding that the intensity and the level of mental health burden is affecting. We don't know which comes first because it's cross-sectional. Does the mental health problem link to the adherence, or does the adherence link, which way does it go? But the associations are there, and the call that we do need to deal with these mental health burdens is very clear, very clear. And then from the study, we also looked at the older and the younger. Not going to go into such detail with you on that, but just to let you know that we used 45 as the cutoff, was sort of taken as a mean age of menopausal, and we did see some interesting differences. Elevated anxiety in the older woman, more above the anxiety cutoff. Slightly more symptoms, both physical and total, in the older woman. More depression above the cutoff. More suicidal thought wasn't significant, but it was so high, 1 in 2 across the age range. And here we've got 1 out of 2 mental health problems, 2 out of 2, or all 3. And we find if they've got all above the cutoff on all 3, the suicidal ideation is elevated. We did give some detail on mental health for the woman, and let's move on to look at what we linked the symptom distress to. It was linked to mental health burden, to adherence, and to sexual functioning. So that's just our small study, but I would like to just briefly tell you about the PRIME study, which is being headed up by Shima Tariq. It's really interesting, countrywide. They've got 22 clinics in the UK, and they're aiming to recruit about 1,000 women, starting to write up some papers. They've got over 1,000 women in the database, and just by way of a taster of the data that's coming from this, they are focusing on menopausal symptoms, and this is just showing you the kinds of symptoms that the group are experiencing. They divide them into premenopausal, perimenopausal, and postmenopausal. So there's sort of 3 groups in the age range, and you can see that there's quite a lot of symptom, and it does change from premenopausal over to peri and post, quite significantly on all of the symptoms, psychological, urogenital, and some of the somatic symptoms. So that's taken me all through the kind of issues around women. And I suppose now I want to move over to what I'm calling little women, to look at children and adolescents. I've mentioned before that children have a kind of a double neglect. They're overlooked by age and by gender. I spoke to you already about that. The classification not giving us the gender. So as I look at children, I want to try and keep in my mind something about the needs of girls, but I don't think we should ever forget the boys. And let's tell you some of the data that we know globally on the children. Now, most of my data comes from Africa, but many people who work with adults don't really have a working knowledge of what's going on with children, and that's really important because as time goes by, these children will be your adults. They're coming through the system, and in in a clinic where we divide by age is very different from a help institution like yours, where you have families and you bring them in. We could even see the lovely painting where we had our lunch, and we thought we might, as somebody explained, that the children and families come in. So having a family lens is really important, and that's kind of how I work. So I'm just going to try and give you some of the overview data. So there's been several systematic reviews on HIV-positive children, and I won't read you all the data, but basically there's very profound evidence that when you take the children with HIV and you score them on standardized developmental scales, the children on the whole seem to be performing at a lower level. Not all children, some children are fine, but if you take a large group and you compare them to a comparison group of children without HIV, you do pick up some specific cognitive delays. And the challenge now is to understand what are the areas of deficit, what are the areas. And so some of the emerging studies, if you start to look at, are finding things like some of the executive skills are more problematic. Now remember, executive functioning skills are the very things you need to negotiate the world, to negotiate safe sex. So it's not just the children are perhaps underperforming in class. Their whole life trajectory is something of importance. The HIV-exposed, uninfected children are also a group that we need to focus on. I've given some data to you, but these are the children who are born from an HIV-positive mother, and they themselves are born HIV-negative. It was always thus. In the whole of the epidemic, there was never 100% of the children born. There was always about between 70 and 80% were virus-free. And now with antiretroviral treatment in pregnancy, the numbers go down dramatically, almost to the possibility of eliminating HIV in vertical transmission. And of course the problem with breastfeeding, in that we do know that breastfeeding can transmit, so children who are born free could then become infected through breastfeeding. And we now know very clearly that if the mother is undetectable, very much like the PrEP studies of what we know about the virus, that if she's on treatment, the chances of breastfeeding transmission also go down. So we have got this whole new B+ program rolling out, where basically once you pick up a woman, she goes immediately onto treatment and she stays on treatment lifelong, which also gives protection for when she conceives her next child. And of course that's obvious that people kept seeing pregnancies as isolated. Women have more than one child and you could protect. So the world has changed, and it really has changed, but these are the children of the future. The majority of children will now be born HIV-free, but exposed in utero. So they're exposed to the virus, they're exposed to the medication, and they're exposed to a household where the child is going to live where HIV resides. And we know that HIV is burdensome, and we don't know what effect it has on the child. So these are a series of interesting studies. We're just showing mortality. The studies were set up to look at HIV-positive children. And the reason I bring them up was some studies took HIV-exposed uninfected as their control group, as well as HIV-unexposed uninfected as a control group. So some good studies had 3 groups, and it's those that I'm interested in, because we know that this is elevated, but I'm not interested in that. I'm interested in this. And look at every point, and those are significant. So we're so busy looking at this, and that's kind of the historical, because now we shouldn't get children born, but this is our future. So that's where the future of understanding this group is. So what are the estimates? These are very kindly UNAIDS provided these to us for Amsterdam, but I'll bring them to you. These are the age groups of the estimates of children living with HIV and children HIV exposed and uninfected. And you can see by age, this is by far the majority in the 0 to 4-year-olds. 5 to 8 years old. The largest is the older children, and they will age out. They will age out. But you can see this is our future. This group is our future, and those are the children who we have to be looking at. So, how do we study these kids? Do we study these? And what do we ask? What are the questions? What do we want to know about the vertically infected or the kids who are maybe in Africa? We're now getting these groups who are infected from their mother during pregnancy, or the groups who are infected through their behavior, and they look very different. So I'm just bringing you some data from some of our studies. This particular study looked at the effects of multiple things on child risk behavior. So here we showed that if the child lives in a healthy family, the chance of a risk behavior in the child, these are adolescents, was 1%. If the parent is sick with AIDS, the child's risk behavior goes up to 7%. If the child is abused or hungry, so they have insufficient food and they're subject to violence, their risk behavior is double that and 13 times living in a healthy. But what happens to the children who have it all? And this is the data that we think is very important. This is the reality of many of the children. They live in an AIDS sick family. They experience violence and abuse, and there's insufficient food. And that's what happens to their risk behavior. So when we're trying to say, oh, we have to give them information about AIDS to change their risk behavior, our answer is no, 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 no. What you have to do to change their risk behavior is stop violence, stop hunger, and help and treat the parent. That's what you've been doing. So I brought you that because that's really, UNAIDS we're hoping, listening to some of the stuff we're bringing. And we're very interested in these combination effects. Now, this data does come from Africa, so I don't know. It'd be interesting to see if you think this is true in your setting. Is this true in London? Not so sure. But here we've looked at the experience the kids have of getting a cash transfer, getting good experience in the clinic, and getting good care. A sort of positive prevention. So we looked at 1,000 HIV positive adolescents, and we looked at what happens to their unprotected sex. And these are positive adolescent girls. So if they've got good parental supervision, school access, and positive clinic care, those are the rates. So if they've got no provision, 1 in 2 having a risk behavior. If they've got any of these, it really dramatically brings down their risk behavior. But what happens if you give them clustering? So they've got school access and good parental care, and we know parental care can be easily learned from good parenting programs, it goes down. If they get good parental care and a good experience in the clinics are quite horrible to the girls. They shout at them. When they come in for pregnancy advice. We're now doing a study on the pregnant teenagers with HIV because they have such a negative experience. And of course, their children will be the third generation, the new generation. But we haven't got that data yet. But here, if you get 2, good school and good clinic, good parenting and good clinic, or good school and good parenting, the risk behaviors come down. And what happens if you're the lucky kids who get all 3? Good parenting, supervision, access to school, and decent clinic care, the risk goes down from 49% to 8%. So when everyone says, well, does all this behavioral, psychosocial stuff matter? Yes, is the answer. Very clearly, yes. It's not about magic bullets. It's not about delivering medications. It's about finding holistic environmental support, and that directly affects risk behavior. It directly affects adherence. It directly affects the very variables that we think are important. And this is just a nice slide on adherence, and we've tried to align it with some of the social protection types. And it's the same message that you can see. If you get no social protection, that's the risk behavior. And if you get everything, so we're looking here at adherence to treatment. It's the same thing for risk behavior and also for treatment. So finally, I'm going to try and show you a little bit of our other stuff. Lots of studies, but this one is showing you our findings on suicidal behaviors, and we just found quite high This is a study of 3,500 adolescents, aged 10 to 18. This is a study in South Africa, and we looked at past month suicidality rates. 3.2% had attempted suicide, 5.8% had clear planning for suicide, and 7.2% were reporting thoughts and suicidal ideation. And what were the predictors of being in those groups? Well, orphanhood by AIDS was a very important predictor for both males and females, and parental AIDS illness was a great big one. So this is the legacy burden. These are the children who are surviving yesterday's epidemic, and they're living with it, and they're very burdened. And this, we've tried to just show you the difference between suicidal ideation and psychological morbidity when there's no HIV in the family. Those are the levels. Remember, these are very poverty children living in great poverty anyway, very demanding environments. And here's a household affected, and if the caregiver is actually HIV positive, and you can see the rates going up. So a lot of mental health burden. Disclosure is a big issue, telling the child, telling them about the status. If you want some good advice, there's been a very nice WHO document giving guidance on disclosure when really thoroughly looking at the literature and saying when should you disclose to a child. I chaired that group, and I think that it's really sensible and well thought through guidance, really saying a child of 12 should know. You know, how you do it is very difficult. And a lovely study by Tams and Rochart reported in the Lancet last year, where they put the Yamagugu trial, where they actually put together a really nice package to train and prepare families for disclosing HIV status. So there is interventions. When we did the study, we actually found that the best adjusted children were those who said they never remember a disclosure moment, they always knew. And that's our advice, really. So you shouldn't have to sit down and tell a child. If you tell the child always, so the child always says, I always knew. When it's like the onion approach, you peel a layer and layer. And these children say, well, I knew from when I asked more questions, I got more information, but I always knew. So in a way, disclosure is a fascinating issue. You can see from what I've been saying that we need to understand bereavement a little bit more. We've got a lot of children who are living with bereavement, either historical death or bereavement. Nowadays, HIV is not creating the same number of deaths, luckily, but there's other losses, there's other bereavements. Loss of distracted parenting, that's a grief for a child. And really, we do know that children whose parents died 10, 15 years ago will live with that fact for their entire life. So we shouldn't let go of that. And finally, I'm just going to try and give you a little bit of information about the HIV-exposed uninfected children. Where is the literature? So this is the state of the global literature. On the biomedical, there is some emerging literature with very mixed ideas. Mixed means there's some positive and some negative. That there's no evidence, and that is there is evidence. And you can just see it's a mixed picture of these children. Is their health, illness, and survival and drug exposure is mixed. No problems with dental health. Some good studies, but things like their own mortality, pulmonary infections, hearing loss, mixed on cancer. No difference on immunization, but that could be more about policy, and there is evidence on tuberculosis. So these kids are getting a very mixed profile in terms of their biomedical, but their cognitive development, there's very good evidence. So we've reanalyzed all the data. Remember I told you before where we sifted through the studies which had HIV-exposed, uninfected, and control groups, and you can see literally on almost every study we do find a difference. There's been a few studies, but this is a really good one, a group, if you want to read up on it, called McHenry, who've actually done a meta-analysis and reanalyzed the data. It's confined to children who are less than 8 years old, but again, they were able to identify 45 studies and found that HIV-positive and HIV-exposed uninfected children showed worse cognitive and worse motor development. So there does seem to be a growing body of evidence that this is a group of children who we need to show. And this is just more slides just showing you. What's really interesting in our review is that we couldn't find any data on adolescents. The data was confined to the younger children. But we did find lots of interventions. So if you say, well, what are we doing? Are our hands tied? No, I mean, I've just summarized the studies, but there's good cognitive rehearsal, stimulation, give them good parenting to the parents, and it's an all beneficial effect. If you treat the maternal depression, the child development scores improve. Nutrition, community support, antiretroviral treatment, disclosure, cash grants, cash plus grants, and parental survival. It's a no-brainer that keeping the parent alive. And be aware that we sit in Sweden where we have good treatment outcomes and good rollout. But think of Nigeria where they've only got rollout to something like 48%. Those parents will not survive if they're not on treatment. The nightmare scenario that we lived with 10, 20 years ago is a real scenario for people who don't have access to treatment. And if treatment was ever stopped, if PEPFAR was disbanded, if UNAIDS and the Global Fund didn't survive, this would be our reality. And we have made amazing progress. Where else in the world have we come up with something like the Global Fund? I think we really should pat ourselves on the back. I mean, you can't. I was in places where you can't get clean water to drink the pills, but these are very complex medications being delivered everywhere. I think we've done very well, but we should keep it up. It just brings in.
I'm just wondering, would you like to take a 5-minute break, or do you want Lorraine to continue?
I'm pretty much at the end, and I think we'll take some questions. I've just literally got one or more two things which I brought because you are a community-based organization, and we've been looking at whether community-based organizations can have an effect on mental health. And I can show you the slides, but really the answer is yes. People said, how can you study this? And I said, you can study anything. And we got 11 funders, and we took every program they had, and we took a random sample. So things like Comic Relief, World Vision, UNICEF, huge funders. And we went out and we took questionnaires, we followed the kids up for a year, we took their caregivers and the HIV positive, and the bottom line is yes. That's the statistics, that's what you tell your evidence-based programmers, but we really can do it. And so the literature really suggests that we should screen, refer and treat, partnering with organizations and providers, broaden the provision, examine tools for assessment and use them, and anticipate mental health issues, prevent and provide, and partner, I suppose. So that's all I've prepared for you today, but I really would hope that we would have time now to have some questions and discussion. I hope yes.
My name is Thomas Wingberg, I'm the chairman.
Hello, thank you very much for your presentation. My name is Thomas Wingberg. I'm chairman of Positive Group, which is an NGO for people living with HIV in Sweden. Maybe I missed what you said before, but I would like to ask you, when you talked about sexual dysfunction, I think is the word you used, right? Yeah. Is that something that is diagnosed officially, or is it your self-diagnosis, which I'm asking because I think that many times you have to diagnose yourself for sexual dysfunction.
So in the studies, I mean, that's a perfect question. And you have the thing is, what is a problem for some person might not be a problem for another person. Right. But in the studies that I'm reporting, what they've used is standardized inventories where people complete and in there is this a problem for you? So so not having, some people are quite happy not to have a partner, and it's not a problem for them. So the inventories, so in a way we have to be a little bit careful with them. It doesn't mean that everybody has a problem, but if you take it in a large group and you do find that a lot of people saying, I have a problem and I've never spoken to anyone about it, it worries me, it upsets me, I wish it wasn't like that. In a way, that's the group who we think deserve some treatment. And we also think that caregivers are not very good at asking about these things. So people hold the information in, they don't talk about it. It becomes a taboo. We can't talk about it.
Yeah, that's why I ask if it's a sort of a self-diagnosed dysfunction, because I found that probably everywhere in the world, this is one of the questions that are less talked about when you...
Yes, I agree with you completely. Yeah. And at some level, when somebody realizes, actually many people experience this, I'm not alone, for them that's a very important moment. Because some people suffer alone and they can't talk about it. And then maybe they come into a self-help group and everyone in the room, and they go, oh my gosh, everyone's having this. And suddenly you've started on the road to help.
Right.
Good.
Hi, I'm Anne-Marie. Thank you so much for your presentation. I'd like to know the difference between mental positive and negative.
Between?
You said mental health positive and mental health negative. So I have never heard of that positive side of it. I thought mental health was negative.
Oh, okay. Yeah. Oh, lovely question. I was trying to think which slide I was talking about. We always, when we're thinking of mental health, we always tend to be talking about depression or anxiety or post-traumatic stress. These are all kind of not such nice things. But on the other hand, you see in my work, you see some children who are very resilient. They're amazing. You know, they've suffered a lot of food deprivation, perhaps parental death, and these kids are working hard and really doing well, caring for other kids. We see in some of the self-help groups, you often see people who say things and you say, what is this? They say, this is the best thing that happened to me. Before I was really off the wall, had a bad life. Now, my life, I have a purpose. I'm helping other people. It's a positive. So I think that, to me, is the positive mental health. And we should balance that. We shouldn't always look for the bad things. We should encourage the good things. And coping is good. I mean, some people cope amazingly. We want to know how, and can we share that with other people? And it's just maybe a philosophy of trying to keep the positive as well. And I'm glad you heard it first from me. Is that clear? Yes, it is. Okay, thank you. Have I stunned you into coffee?
Just to mention, one of the issues was whether this is... Okay, so I'll keep quiet, shall I?
No.
Yeah.
What's your question?
I'm not allowed to.
No, you've got a mic. You don't have to use mine.
One of the issues, whether this is with sexual problems or with mood or other issues, is that much of what the person is prepared to talk about depends on how they're going to be listened to. So if the practitioner, whether it's doctor, nurse, counselor, whatever, is going to panic and not handle it, then obviously you don't generate those questions. But also, even if you're sympathetic, if you have no way to refer this person on to something more specific, so it depends on the whole context. Just simply being nice to people and saying, yes, tell me all about your problems, unless you have somewhere to go to. And I think that's where we often fail. We know what the recipe is. We know what the things we need to do are, whether this is supporting people at school or intervention to help parents to handle difficult situations. But if those things aren't there, then you just get stuck with the evidence but with no action. And then the practitioners sort of shy away from it. Because what's the point of identifying problems if there's nothing I can do? If everybody's depressed, I'm just going to get depressed because they're depressed as well, because I don't know what to do. So it's part of a sort of range of approaches. It's not just us doing the right thing. We need to be in the right context in that sense.
And we've in the past we've done things where we've videoed interviews, and you look at the questioning style, and there's a lot of, we call it blocking questions, where people ask about, they say, oh, I asked about it, They didn't tell me. And so when you analyze, they say things like, "You don't have any problems, do you?" So they believe they've asked, and the message to the client is, don't go there, don't mention your problem, because it's the way they framed them, and so you have to be able to show you really want to hear them, or you've got the time to listen. Otherwise, you're right, Pepe. People will just not feel, or they'll say the doctor's very busy, and it's more important they get my drugs right. So in the room they will rank order what they discuss, and they will discuss what they think the doctor thinks is important. Do any of you work with children? Work with children?
I meet some children that live with HIV and also not children. Yes, I meet some children who live with HIV, and I meet also children who lives in families with HIV.
Yes, of course.
So,
Yeah. And we don't ask about that. We did a study once, it's a while ago now, where we asked MSM about their dreams of fatherhood and if they had children. And everyone said, "Why are you doing that?" Wow, very interesting data we found. Many have children, many dream of fatherhood. We make all sorts of assumptions. So, often I have people say, "Oh no, I work with MSM." I think, "Oh yeah? Well, come on, So...
I have one question about breastfeeding.
Yeah.
Is it any studies that is going on about the next step about breastfeeding and when the treatment is so good nowadays?
So there's continued monitoring studies, and the new regime, the B+ regime, is really meant to encounter that, because in the past they would prevent mother-to-child transmission and the mother would stop treatment, which nowadays it's treatment for life. So there is monitoring. There's not really studies because it's sort of unethical now you can't have a woman and not give her. So there might be some studies that's comparing the compounds. And that's not in my area of expertise, but I know that in Amsterdam there was a large issue that came up from the Botswana group who are monitoring, and dolutegravir was having a higher than expected rate of neural tube issues. So there's discussions about which compounds should be used in pregnancy and maybe in breastfeeding. But that's where it is. I think the treatment guidelines are treat during breastfeeding, and it's released them from the previous things of exclusive breastfeeding and formula feeding. And the reduction of transmission postpartum has really helped enormously by onward transmission. Yeah.
Thank you.
Pleasure.
This is not so much a question, but a reflection. I think you used the word disclosure. Yes. I've been living with HIV for almost 30 years, and one of my strongest memories is when I saw, this is way back in time, a young boy. There was a documentary or something about him, and he never got to know from his parents, but he saw on television and identified another man talking about his AIDS at the time, and he realized himself that this man on the television had the same diagnosis, the same sickness as I have. And this is a very sort of heartbreaking, strong memory from, he had to deal with it himself because, this was not, the advice was probably never to tell him. And he found out himself by looking at television when another adult person talked about AIDS. So I think this is a very important subject, and your conclusion is probably the right one. Yeah.
There's so much on disclosure. I agree absolutely, and if you, the cycle of secrets is very damaging, and you're absolutely right. I mean, this is one example, but very often you have children who just know. And I mean, I can tell you about cases. There's one that's a long time ago, but I remember very clearly the parents couldn't bring themselves to tell the child, and the child was quite poorly. So the clinic set up a big, complicated situation where they would go with the parent, and they rehearsed and they role played with the parent. So they were going to prepare the child and prepare the parent. And the parents just couldn't, and the parents asked the clinic to talk to the boy in advance, which I think is bad, but anyway they did. And the boy said, "Oh, I know." He said, "I read it on my I know." He said, "But please don't tell Mummy and Daddy, because they'll be very upset." So the child was colluding with a secret. The child knew, and the child kind of had taken it on board. So we have all these crazy situations. But while we have stigma, we have disclosure challenges. And remember that when you disclose to a child, you're not only, it's not like telling a child of about cancer, because you're also telling the child about the parental status as well, and that makes it a little bit more complicated. But, you know, the old psychology advice is, if in doubt, tell the truth. Because the truth could be painful, but at least it's the truth. Yeah. That's it?
I was just wondering about the uninfected children in the HIV family. I was surprised about that there was some more people in the studies over there. You had data on physical consequences that had been shown. But is there any material? Have you any studies about the psychological well-being of uninfected children in a family where one or several people are HIV positive themselves?
It's such a big area. Yeah, it's a great question. So this is sort of a very new area of study. We do have some data. Our study is from Malawi, South Africa, and Zambia. And we do, I mean, there is a burden for these children. And they divide very differently. What's very interesting is there's children who have sick parents, there's children whose parents are deceased, and there's children who are moved to another family because, and in a way, it depends on what stage they're at and historical. But the data from the big cohort with Lucy is showing that historical AIDS and parental death and parental illness is having an effect on the mental well-being of children. And we need to unpack that. We need to understand what it is. But we can understand that there's, first of all, bereavement, loss of a parent, irreplaceable, but then sickness, very diverting. A parent who's worrying about HIV is not concentrating on being a stimulating environment for parenting, all of those things, very diverting. And we also know that parents who are depressed, the children don't develop as well. This is from the general literature. And we also know that there's a lot of depression associated with HIV. So a lovely study by Mark Tomlinson and Mary Jane Rotherham-Boris have shown that if you put in, and it was a very easy study, they put in a mentor mother training her on mental health into the homes of postpartum women. So this is young children. And they showed that the development of the child improved when you treated the maternal depression. It wasn't development intervention, it was mental health for the mother intervention. So it's a growing literature, it's all over the place. So there was a very nice satellite meeting that we pulled together in Amsterdam, just focusing on this group. And we've now applied for funding to look specifically at this group, but they haven't really had the attention that we need to be giving them.
Yes, I was wondering if your experience, according to your experience, if they are forgotten or if their needs are addressed to, as well as the children who are HIV positive themselves.
Yeah. They are really overlooked. So the people who are doing very good work is somebody called Kate Powers in Canada and Amy Slowgrove in Stellenbosch. And there's some nice stuff going on in Botswana. And I think we're trying now to create an international collaboration to pool the data and to look at these children. And many of the families say, oh, once the child's born negative, we don't want to, that's it, you know, close that chapter, we don't want to talk about HIV, just get on with it. And they don't want the child. But if the child has needs, we need to understand them, so. I can't think of one study in Europe that's following these children. But we hope we get funding and become the one. Join us. Yeah. Tomorrow's problems. We're always thinking of yesterday's problem, not tomorrow's problem. Good. Tea time.
Well, I would like to generalize a little about Swedish people. We are a bit hesitant sometimes to express our questions or comments in the public like this. But as there will be some coffee, you might be really heard a lot of questions and comments.
Very welcome.
So I think, unless there are some more comments or questions, maybe we should take the coffee break right now, and for about half an hour, and then we can go on with Jose, and that will give us a little bit more time for the Golden Ark and to mingle after that, so you don't have to rush away right away to the cab and the airport. So I want to thank you very much. There is a lot of important facts here that we really have to consider, and I think it's really interesting that children are very much forgotten, even in this country, I would say. Both those who do have HIV infection, but also those who do not have infection. So I really hope that this was some, your emphasis on women and children, that is something we can take with us and see how can we develop our work within our NGOs, and don't always trust the healthcare system. Okay. Thank you.
Thank you.